Alright, so here's my nursing care plan. Patient summary. My patient's initials are ES, and that is what I will be referring to him as. He is a 91-year-old male admitted for a left femur fracture due to a fall at home. The details we have about his fall is that it happened when he was getting out of bed. He was on the floor for 20 minutes and denies weakness, dizziness, loss of level of consciousness. But the cause of the fall is unknown. He said he kind of just fell to the floor. He has no known drug allergies. He's a former smoker. He said it was quite a long time ago, so that quick date he does not remember. In his charts, I found that he's an everyday user of either vapes or e-cigarettes, however. He's married and lives with his wife. His wife was nice. She visited. I really enjoyed getting to talk with her. And she is dealing, unfortunately, with her own health problems. After ES leaves the hospital, he will be going to rehab. He has dentures and glasses. However, he has no hearing assistive devices. I did not find myself having to repeat myself very often, and I think for his age, he had a very good sense of hearing. Surgical history. He has not had many surgeries in his lifetime, starting with his cataract extraction with an ocular lens implant, meaning he had his cataract removed and then replaced with a clear artificial lens. He has had a hip arthroplasty and a knee arthroplasty, meaning that those were replaced, and his most recent surgery being an ORIF, which is an open reduction internal fixation. This was due to his left femur fracture, so it was only within the last few weeks here. Imaging and diagnostic tests. His chest x-ray was performed on 10/23/22 with no acute cardiopulmonary abnormalities found. His ECG was also performed 10/23/22, sinus rhythm with premature supraventricular complexes, left axis deviation, low voltage QRS, inferior infarct, age undetermined, and myocardial infarction finding now present, meaning that he had to have had some level of a heart attack, and that timing that it happened is unknown. He had a left femur x-ray performed again on 10/23/22, an acute spiral fracture of the distal femoral shaft with overriding, mild displacement, intramedullary rod, and nail in the left femur were found. Continued is his ultrasound ECG, both with and without contrast. This was performed on 10/24/22. Findings include preserved left ventricular systolic function with no regional wall motion abnormalities observed in the limited windows. Left ventricular ejection fraction was 68%, which is actually a pretty good percentage considering his age. And lastly was his CAT scan of his left femur without contrast. This found mildly displaced and angular ED spiral fracture of the distal femur between the intramedullary rod and femoral component of the total knee arthroplasty. This was a 7+ butterfly fragment, and this was anterolaterally. Oof, I struggle a little bit with those words. Lab abnormalities as of 10/26/22. Within his CBC, all of his lab findings were off. His white blood cell count was high, my mistake, at 12.1. His red blood cell count was 2.77, which is low. Hemoglobin, again, was low at 7.8. Hematocrit was 23.9, which is low, and his platelets, shockingly, were 61, which is, again, low. I believe majority of these lab abnormalities to be due to his anemia. And the functional health pattern this falls within is activity exercise. Next is his chemistry labs. His sodium lab was low at 135. Calcium was low at 8.0. BUN was 50. Creatinine was 2.28. And GFR was 26. Now, these last three labs I listed all have to do with the kidney filtration, function, all about their ability to do their job. And because one of his diagnoses that I will get into later is hypertension, these three are heavily affected by that. His sodium may be high due to his retention because he's unable to urinate, again, due to one of his medical diagnoses that I will get into later, which is BPH. And his calcium could be because of his immobility. He's not getting around as much, and he's been very contained to his bed. The functional health pattern I consider to be elimination. Now, let's talk about the good stuff, which is his labs within the normal ranges. His normal ranges only were within his chemistry lab. Starting with potassium, we're at 4.6. Chloride is 103. CO2 is 26. Glucose is 106. Folate is 12.6. And vitamin B12 is 370. Medications I gave, starting with the atorvastatin, the dosing was 20 milligrams oral daily. This is for the prevention of heart disease, and the functional health pattern would be nutritional metabolic. Second is finasteride. Dosing is 5 milligrams oral daily. This is for his benign prostatic hyperplasia, functional health pattern being elimination. Third is carvedilol, 12.5 milligrams orally every 12 hours. For his hypertension, functional health pattern being activity exercise, and then lastly is his enoxaparin at 40 milligrams sub-Q daily for DVT prevention, functional health pattern being activity exercise. Alright, other medications that I did not get to give were his IV normal saline flush. This is done every shift, a 10 milliliter in his IV. This is to maintain the clearance and patency of the IV. Functional health pattern being nutritional metabolic. Second is his cefazolin, 2 grams within 20 milliliters IV push every 8 hours. This is a perioperative prophylaxis, meaning this is given before surgery in order to help prevent potential infection. Functional health pattern is health perception management. Third is lactated ringers, given at 75 milliliters per hour, continuous through the IV. This helps replacing those lost fluids. Functional health pattern being nutritional metabolic. Lastly is his iron sucrose, also known as Venofer. 250 milligrams in sodium chloride, 0.9%, in a 250 milliliter bag given daily through the IV. This is administered at 180 milliliters per hour. This is given due to his anemia, and the functional health pattern being nutritional metabolic. His reason for admission is a left femur fracture due to a fall at home. His top 5 medical diagnoses are BPH, which is benign prostatic hyperplasia, osteoarthritis, CHF, which is congestive heart failure, history of falls, hypertension, anemia. Oh, my bad. Those are now getting to his other medical diagnoses is anemia, COPD, unsteadiness on feet, and asthma. In the next few slides, I will be talking only about his top 5 medical diagnoses, diving deeper within them. Number 1 is osteoarthritis. This is a joint deterioration disease that can lead to bony outgrowths, spur formation, pain, limited joint mobility, decreased exercise tolerance, stiffness, and decreased bone density. This can be caused due to aging, obesity, history of injury, overuse of the joint, family history, and stress to the joint. Now, how can this relate to his left femur fracture? Well, osteoarthritis can decrease motivation to exercise due to the pain, exercise tolerance, and bone density. This contributes to weaker bones and it heightens the chance of bones breaking. Hypercalcemia also occurs from the bones leaking, meaning if you do not use your muscles and your bones, if you're not being active, calcium can actually leak from the bones into the bloodstream. Also, a prolonged healing process. Number 2 is a history of falls. A fall is an unplanned descent to either the floor or level below you. This can result in injuries, including broken bones, head injuries, and sprains. This is caused from body weakness, a vitamin D deficiency, because vitamin D helps with the intake of calcium. So if you're not intaking vitamin D, your body will have a little bit of a harder time taking in the calcium. Signs and symptoms of medications. Some medications can cause dizziness, vertigo, blurred vision, which is also a cause, and a hazardous environment. How does this relate to a left femur fracture? Well, there is a potential injury with falls. You can have difficulty performing ADLs independently. People fear falling, especially at the age my patient was at, so they may decrease their activity overall, and like I stated before, inactivity makes you weaker. Number 3 is hypertension, also known as the silent killer, and I'll tell you why. Hypertension can go without signs and symptoms in the early stages. Typically, when you start experiencing signs and symptoms, you are farther along the disease process, and your kidneys can be as much as 65%, down to 65% production, like ability to work. In order to be diagnosed with high blood pressure, has to be consistently above 140/90. This is caused by something we do not know, but it can be associated with stress, age, obesity, and a poor diet. How does this relate to a left femur fracture? Well, hypertension can cause confusion, blurred vision, dizziness, especially with orthostatic hypertension. We have to make sure we are educating our patient on how to handle orthostatic hypertension and how to avoid the dizziness. Increased risk for heart failure or attacks, stroke, renal failure, and blindness, and heightened atherosclerosis, creating a heavy workload for the heart. Next is CHF, also known as congestive heart failure. This is when the heart muscles do not pump blood as well as it should. This causes activity intolerance, decreased exercise, fluid buildup in the lungs, shortness of breath, edema, and weakness. This happens potentially to a past heart attack, hypertension, diabetes, alcohol or substance use, sleep disorders, and chemotherapy. This relates to the left femur fracture because of the shortness of breath, activity intolerance, prolonged healing process, decreased circulation, fluid buildup in extremities, and difficult range of motion. Lastly, of his top 5 medical diagnoses is his BPH, also known as benign prostatic hyperplasia. This is a non-cancerous enlargement of the prostate gland, so because of that, this is only happening in males, commonly caused by an obstruction of urine flow. Commonly causing an obstruction of urine flow, leading to the muscles inside the bladder to enlarge because it's trying to force out that urine. Over time, because that bladder's working hard, it will get thick and irritated, it can get weak, you can suffer urinary retention, and an increased chance of a UTI or chronic renal failure. This happens due to hormone changes, age, family history, obesity, heart disease, circulatory diseases, diabetes, and low exercise. This relates to the left femur fracture because of the urinary retention and the irritation to the bladder. The patient may be taking frequent trips to the bathroom, increasing the chance of falls happening, especially if he is in a rush to get there. This can also cause balance issues and decreased mobility. My nursing diagnosis is? My first nursing diagnosis is decreased cardiac output related to altered blood pressure, evidenced by myocardial infarction finding now present. The functional health pattern is activity exercise. All right, assessments. You will want to collect vitals, level of consciousness, chest pain, capillary refill, peripheral pulses, heart sounds, respiratory characteristics, I&O, skin color, and temperature. These are all to be completed every shift. Interventions include providing a stool softener. You do not want this patient straining on the toilet because that can increase blood pressure. Administer pain meds. These are both done as ordered. Provide comfort measures, educate on rest between activities, reporting signs and symptoms of the heart overworking, avoiding caffeine, alcohol, and smoking. These are all also to be completed every shift. The goal for my patient was that his blood pressure would remain within the patient's blood pressure range. His blood pressure range was 100 over 49 to 125 over 60 from 10/25/22 through discharge. The goal was not met. The patient's blood pressure did not remain within the patient's blood pressure range, which was 100 over 49 to 125 over 60 again, from 10/25/22 through discharge. Number 2, risk for infection due to surgical procedure. Functional health pattern being health perception. Assessments. You want to assess every shift that the dressing is intact, signs and symptoms of infection being warmness around the surgical site, a fever, any pain, symptoms like that. Assess vitals, history of infections, complete blood counts, because that white blood cell count is a great indicator for infection, and his nutritional status. Wound healing has a lot to do with the diet. Interventions. Ensure the clothing the patient has on are clean. Encourage fluids, wear proper PPE, especially when dealing with the surgical site, and you want to limit visitors. Now, you cannot deny visitors, but you can encourage him to maybe call them instead or FaceTime them because you want to keep that risk for infection as low as possible. You'll want to educate on a balanced diet and the importance of keeping that site clean, especially when he is out of your care. These are all to be completed every shift. My goal or intervention for him was that the patient will remain free of signs and symptoms of infection from 10/25/22 through discharge. This goal was met. The patient remained free of signs and symptoms of infection through 10/25/22 through discharge. Lastly, my third nursing diagnosis was impaired physical mobility related to his left femur fracture, evidenced by inability to transfer independently. Functional health pattern being activity exercise. During the one transfer I saw, therapy came in and he was a full assist. He had 2 medical staff helping transfer him, but he did get from the bed to the recliner. Assessments include promoting independence with ADLs, pain level, need for assistive devices, I&O, safety of the environment, emotional response to limitations, and skin integrity. That, I believe, is one of the most important. Being that he is very bedridden right now, making sure that skin is intact, there's no pressure, sores, or any redness is going to be very important. And these are all to be completed every shift. Interventions, you want to provide assistance when needed during ADLs. Maybe he wants some water, anything you can help him get, being that he is not going to be getting up and walking to get it on his own. Keep his skin clean and dry. Apply SCDs or compression stockings, especially after surgery, to avoid those DVTs, and perform range of motion every day 4 times. Educate on proper use of the assistive device. Him, it's a walker. Benefits of a balanced diet and early ambulation. The earlier you can get the person to ambulate, the better. And this is again to be completed every shift. My goal is that the patient will be able to transfer independently by discharge. The goal was not met. Like I told you, that transfer was not done independently, so he did not meet the goal by discharge, unfortunately. These are some of the sources I used. And thank you. I hope you enjoyed my presentation and that you learned some stuff about my resident and how his diagnosis is related to his admitting reason.